Thank you, Anna and Hunter's Hope, for giving me the opportunity to talk about these recommendations that were long in coming and difficult process, but I think are going to be quite helpful for the clinician. These recommendations are really aimed at the clinician who gets the positive screen and has to figure out what to do with it and how to communicate the appropriate risk level to family, and also hopefully will be important for the newborn screen labs to understand, what the clinicians need in terms of the data. Next slide. So I'll mention all the co-authors at the end, but basically you could see the group there for this publication that came out earlier this year. This was a result of the Krabbe Disease Newborn Screen Council that Dr. Kurtzberg was just talking about, organized by the LCN, and you can see all of the different types of individuals who are involved in that. Discussions occurred between July 2017 through 2020 through an iterative consensus building process, and we were able to achieve over 90% agreement in the group. Next slide. So basically, these are the two main questions that we were trying to answer. One, now that we have psychosine, which is an incredibly important test, how do we include that in the algorithm to help classify or stratify babies to a specific diagnosis, whether they're at risk for early infantile form, later onset, or unaffected? And then the second major question was, once we know that a child might be at risk for late onset Krabbe disease, what kind of clinical follow-up and testing would we recommend that clinicians employ for those patients? And for that question, we did a literature review that was really done primarily by Dr. Margie Ream into the data that's available. And there's a lot of question marks there, but we did our best as a group to provide some reasonable recommendations. Next slide. Okay, so here's the main idea. Okay, as a clinician, we are going to get an alert that a baby screened positive for Krabbe disease. And as you all know from listening to this morning's presentations, what we get in that alert might be quite different based on the state, but we'll be getting this alert. And what we need to do as the clinician getting this alert is to quickly try to separate the patients into the babies into these three categories. One would be early infantile Krabbe, the babies who are at high risk for developing the disease early on within the first 6 months of life. And for those babies, we need to get them into the clinic emergently, draw blood for follow-up, but then refer, as people have mentioned already today, for a transplant evaluation before those follow-up tests even come back. So that's an emergency. The second would be at risk for late onset Krabbe, where we need to get the patients into the clinic urgently, I would say within 2 weeks, draw blood for follow-up testing, wait to see what that testing shows to understand risk. And I'll go through that a little bit more in a moment. And then the third category, which is very important to identify, is the babies that will be ultimately unaffected and don't need long-term follow-up. Actually, I just recently got a referral for a baby who was highly likely to be unaffected, most likely carrier plus pseudodeficiency. And when I called that family that day, so I called them sort of the day of that I got the alert, one of the first things I said after introducing myself was that it looks like basically this is going to be a false positive, explaining what that meant before I even went through everything else that I said, because that kind of reassurance is incredibly important. Okay, next slide. So as the clinicians are trying to stratify into those categories, this is the information we need. Okay, and number one, as people have talked about a lot, we need the blood psychosine level. Usually we're talking about the dry blood spot psychosine, which is the numbers that we've been giving you today. Dr. Matern is also developing a psychosine level in erythrocytes, which actually has different numbers. So that's something that could be helpful as well in the future. But here I just put blood cytosine level. We need measurement of the GAL-C activity in leukocytes. That's usually done by the referring clinician. And the GAL-C, the gene, genotyping of the GAL-C gene. And that might be done by the newborn screen lab, or it might be done through the clinician, depending on the state. So those are the 3 important tests. And as was already mentioned, it's important to note that for the cytosine, congruence has been achieved with 3 specific clinical laboratories. And it's important that any lab offering cytosine really has to make every effort to have comparable results to those labs. And that's mentioned in the paper, if you want more detail on that. Next slide. Okay, so in terms of the classification for early infantile Krabbe disease, as was already mentioned, their dry blood spot cytosine should be high. And we're defining high at this time as over equal to 10 nanomoles per liter. And if that's the case, then we will be interested in the genotype and in the leukocyte GAL-C enzyme activity, as you can see here, but we will not be waiting for that information before we refer for a transplant evaluation. But technically also in the criteria is a GAL-C enzyme assay in the Krabbe disease range. Next slide. I'm going to skip to unaffected. So for the babies that are most likely false positive, they should have a leukocyte GAL-C enzyme activity above the range reported in affected patients, and should have a normal cytosine level on dry blood spot, which we're defining as less than 2. There are some areas here for inconsistency or not being able to meet these criteria. So if you're in a state where the newborn screen lab gives the genotype, what do you do if the cytosine is normal, but the genotype is concerning with 2 possibly pathogenic mutations? Another possibility is, what if the leukocyte enzyme level is in the affected range with a normal cytosine? So in these cases, these would be great opportunities to discuss with the newborn screen council, possibly to follow those babies, but we feel that those situations are going to be very rare. Next slide. So you saw this slide a moment ago. So this is how we stratify for late onset Krabbe disease. So this is a really big challenge, late onset Krabbe disease, and has been for many years. And what we're trying to do through this classification is to make a distinction here between high risk for onset in early childhood and low risk for onset in early childhood. Now, I'm not saying high or low risk for developing the disease ever. Really, it's important to note that we're talking about high or low risk for onset in early childhood. And the point of that is we want to make sure that we are, when we're thinking of the frequency of testing, that we're not over-testing babies who really are at very low risk to develop the disease early in life, if they develop it, but also do enough frequency of testing for those at high risk for developing it early in life. So that can be a real challenge. Next slide. So to go through that, it really, the major way that we're trying to distinguish there is based on genotype. So you can see here the criteria. So for at risk for late onset Krabbe disease, the leukocyte GAL-C enzyme activity should be in the reported range for Krabbe disease. And the cytosine on dry blood spot, the concentration should be in the intermediate range, which we're defining as greater or equal to 2 to under 10. So for example, some of the numbers that were used, like this morning, if there was I think in one of the presentations, perhaps Illinois, we talked about numbers between 2 and 3. According to our discussions, we would consider someone between 2 and 3 to be potentially at risk. And we want to know the genotype information and probably put them into one of these at-risk categories rather than assigning them as unaffected. So that intermediate range is very important. And then for those at high risk for onset in early childhood, the genotype should be suspicious for Krabbe disease that could cause early infantile Krabbe, basically. Okay, so 2 known or likely pathogenic variants associated in the, or known to be associated with, or presumed to be able to cause early infantile Krabbe. Now, I admit, and our group admits, that this can be a little bit challenging. And there's a lot we don't know about variants of uncertain significance and the genotypes in general. But there is some information that we've learned. And by we, I mean not me, but others, including Dr. Wenger and Dr. Orsini and others over the years, especially in New York State, doing a lot of these genotypes for Krabbe disease. Next slide. And then for at risk, but lower risk for onset in early childhood, we basically have the same first 2 criteria. And then we're gonna, then when you're looking at the genotype, we would think that it appears to be low risk for onset at that age. So this would be, for example, variants that are known to cause or be associated with juvenile or adult onset disease. Now, like I already mentioned, there are going to be cases where it's just not clear, and there's variants of uncertain significance, or there's a novel variant. And for those cases, that'll be a great discussion with the council. Next slide. Next slide. So that brings me to this slide, which is going to be the conundrum in these cases for the clinician getting this information. How do we figure out low versus high risk? And I think it's absolutely essential for most cases to really be brought to the experts, especially the experts in understanding genotype and what the different variants mean. And that is a great type of case to bring to the newborn screen council that Dr. Kurtzberg was just talking about. And we're excited about those cases. We really want to hear about them and help with the decision making. Next slide. So this is just a summary of what I've just talked about. This is from the paper, and you can see there in the top left, a neonate is identified with a positive screen. The clinician will either get the cytosine through the newborn screen lab or should emergently send for a blood cytosine level if they're in a state that is not providing cytosine. Then you can see that if the cytosine is high, so over 10 for the dry blood spot, then you're going to get the other blood work as well, but you're going to make that immediate referral. For the cytosine intermediate or normal, if this has resulted to you, some states would not result if cytosine is normal, but if it's resulted, then we're going to determine the GAL-C activity in leukocytes and the genotype. Moving to the right side there, if the cytosine is normal and the GAL-C activity is above the range of affected patients, then this is going to be somebody who is likely to be unaffected, and that reassurance, that quick early reassurance is incredibly important for these families. I've seen a fair number of unaffected, and I feel like if we have great communication and we understand the results and we have that early reassurance, that we can really get parents through it pretty quickly. And then, of course, if in the middle there, if the GAL-C activity is in the affected range with that intermediate cytosine, then we're going to rely on the genotype to try to help understand risk for disease in early childhood. So that's just a summary. Next slide. So that answers the first question. I think that we've come a long way in being able to stratify those babies. The second question is also very important for the clinician. We have somebody who we feel is at risk for late onset Krabbe. What do we do now? So why don't we move on to the next slide? So for those considered to be high risk for disease onset in early childhood, we recommend that these babies be seen every 2 to 3 months in the first 2 years. And we recommend that that be by somebody with expertise in leukodystrophy care, hopefully. And then every 6 months until age 3, annually until age 12, and then every few years. And the reason for that distribution is that babies who have the onset of Krabbe disease, or those who have the onset in infancy, are much more likely to progress very rapidly. And if you're not seeing these babies frequently, then you could miss the window for treatment, and we really do not want that to happen. And then as the individuals get older, then the rapidity of the disease slows down. So that's how we can kind of spread out those visits. And at each of these visits, of course, we should be doing a comprehensive history and exam. We should be going through that list there on the right of signs and symptoms. We should be counseling the family. We actually are, myself and a group through Hunter's Hope is coming up with a family guide that can help the families understand some of this, which I think will be very useful. And if any signs or symptoms develop over this follow-up period, then those patients should be urgently tested at that time within 2 weeks. And I'll go through the tests on the next slide. So next slide. So here's the tests that we recommend. This is very challenging because the state of the literature is not very robust in many ways, although there's a lot of great work that's been done, including by Dr. Maria Escolar in this area. So you could see that we're recommending as just the screening for those at high risk for disease at early childhood, an MRI scan of the brain, along with diffusion tensor imaging, if that's available, nerve conduction studies, and repeat blood cytosine levels. The evoked potentials, the BAER is the brainstem auditory, and then the VEP is the visual evoked potentials, might be helpful, but that was a little bit less clear. And a lumbar puncture for elevated protein is invasive and might be helpful, but we didn't think that that was obligatory in every patient, but might be helpful if the results that we're getting from those 3 core tests are unclear in some way. So we'd like these tests to be done within the first 2 months of life for these babies, and then approximately every 4 months through the first year. After that, we're going to space them out to approximately every 6 months till age 3. And then after 3 years old, we recommended annual testing with an MRI scan and a blood cytosine with possibly those other tests if needed until age 12. And if they get to age 12 without having any signs of disease, then just every few years they could get an MRI scan until adulthood. And with this strategy, we're hoping that we'll be able to capture those who we need to capture who are going to be at high risk, but through our stratification, not do a lot of unnecessary testing for those who are at low risk. Next slide. So for those based on genotype who are felt to be at low risk for disease onset in early childhood, the clinic visit itself will be the same, but just less frequent. So we're recommending every 6 months for the first 2 years, and then annually until age 12, and then every few years until adulthood. Next slide. And then the testing protocol is much simpler. So we basically would still like these infant toddlers to get baseline testing with an MRI scan with DTI, diffusion tensor imaging if possible, nerve conduction studies, and blood cytosine level with the option of those other tests by 18 months of life, just so we can get a baseline and make sure that there's nothing of concern on there. And then an MRI scan of the brain every few years until adulthood. But we do not need to do that very, very frequent testing for these infants and toddlers whose genotype is associated with variants that have been seen in juvenile and adult onset disease. So with this strategy, this classification and testing strategy, the group in the paper did do a historical review of a New York State cohort of 47 newborns using the 2019 criteria, which did not have cytosine, and these criteria that we were recommending. And what we found was in these 47 newborns that with the previous criteria, it would have been recommended that the whole group over their first 2 years of life undergo 952 diagnostic tests. And with these new criteria and the new stratification system that we're recommending, that whole cohort would actually only need to undergo 118 diagnostic tests for the first 2 years. That's for the whole group, which was an 88% reduction in the total amount of testing required. So I think that we're really doing much better to focus our testing strategy on those who are really high risk and need that testing. Next slide. Okay, so that was a brief summary. There are some examples in the paper that you could look at. I didn't have time to go through examples today, but I wanted to just review what we talked about. Thank you again to this wonderful, amazing group of mentors and scientists and clinicians. Dr. Kurtzberg, especially, who served as a mentor for me on this paper, as well as Dr. Ream, Dr. Gelb, Dr. Matern, Dr. Orsini, Dr. Levy, Dr. Rubin, Dr. Wenger, Dr. Burton, and Dr. Escalar, who are all extremely important in those discussions that were had over the last 3 years.